Hi, doctor. It's about Mr. Sleeve, the one with the pneumonia.
Yeah.
His sputum cultures have come back and it's positive for strep pneumoniae. What would you like to do?
Just give him antibiotics.
Okay, which one would you like?
Uh,
Doctor?
500 milligrams of meropenem IV.
Isn't that like super broad spectrum?
Stop!
Who's been prescribing broad-spectrum antibiotics to every man, woman and child in this hospital?
It's me, Professor.
You need to learn a few things about your poor prescribing habits. Here's what I think you need to learn.
I just finished 4 years of medical school. Why do I need to learn this?
Because you as the junior doctor are going to do most of the prescribing in this hospital, and you need to be safe.
Okay.
Now, antimicrobial resistance, as I hope you already know, refers to the concept of potentially pathological microorganisms developing resistance or immunity to antimicrobial therapies. Now, when you repeatedly expose microbial populations to antimicrobial agents, those with resistant traits survive. These traits might be spread between organisms or passed on to their progeny, promoting the survival of the resistant populations. It's a natural phenomenon, but the rate at which this is occurring is accelerated by the misuse and overuse of antimicrobial therapies around the world. The commonest and perhaps most urgent emerging trend of this would be antibiotic resistance.
Can't be that big of a problem in Australia. Surely all that resistance stuff doesn't happen much at all.
It's not as rare as you might think. Resistance to antibiotics, including last-line therapies, has been documented in every region of the world. The problem was recognised in 2015 at the 68th World Health Assembly, when 196 member states endorsed a global action plan on antimicrobial resistance to prepare national action plans and promote the development of new antibiotics. And as for Australia, well, our rate of antibiotic consumption is amongst the highest in the OECD. In fact, 45% of Australians were prescribed antibiotics at some point in the year 2013.
That sounds pretty bad. So what happens if we can't get it under control?
Modern medicine relies heavily on antimicrobials to combat infection. Without them, we'd be unable to treat simple infections, and interventions like surgery or chemotherapy would be extremely risky. Now, in the US, resistant infections already cause 2 million illnesses a year, and they kill 23,000 people a year, not to mention the $35 billion in costs to society. The impacts on morbidity and mortality of widespread resistance would be astronomical, and the associated costs would likely cripple any health system.
All that? From prescribing a few broad-spectrum antibiotics?
You're not the only one prescribing unwisely, my young friend. Injudicious use of antibiotics occurs in healthcare settings, agriculture and the environment, and it breeds resistance all around. It's a scourge which must be attacked on many fronts. We must coordinate to reduce and contain the spread, whilst fighting back against the malignant microbes.
Whoa, okay, calm down, Professor. At least we have a lot of strong last-line therapies up our sleeves, and pharmaceutical giants are pumping out more every day.
Wrong! Multi-resistant organisms have already been discovered with resistance to last-line therapies, including carbapenems, all the beta-lactams, even colistin. And as for new developments, a report by the WHO showed that as of May 2017, the 10 antibiotics that might reach the market in the next 5 years will add minimal benefit and are insufficient to combat the threat of antibiotic resistance. The collapse in research and development is due to the poor economic margins in the sector, and pharmaceutical companies keep pulling out.
That's a pretty scary picture you're painting there, Professor. How can we fix it?
I'm glad you asked. Infection control and reducing the spread of bacteria is important, but mostly, I think we need to fix your bad prescribing habits to prevent the development of more resistance. Now, why do you think you're having trouble with the prescribing?
Well, come to think of it, at times I think I have a lack of knowledge when prescribing antibiotics, and because of that, I have a lack of confidence. Also, when I have trouble prescribing antibiotics, I am unsure of which guidelines that I need to look at, and when I'm unsure, I don't really know who to talk to.
Well, you're not alone on that one, son. In fact, the literature shows that the key drivers of injudicious prescribing habits include lack of knowledge, lack of confidence, lack of clear guidelines, and lack of senior support. A survey of first-year junior doctors showed that doctors were neither confident nor competent in prescribing antibiotics due to a lack of education and knowledge. Further evidence suggests that education during medical school may not provide sufficient emphasis on principles of clinical pharmacology, knowledge of drugs and therapeutics, and the practical prescribing skills necessary to meet the demands of a junior doctor in a busy hospital setting. This lack of knowledge and inadequate training may make it more difficult for students to transition from student learner to busy hospital prescriber, which may contribute in turn to the lack of confidence experienced by some junior doctors. Now, in terms of junior doctor prescribing confidence, the literature has shown that junior doctors were most confident when making a diagnosis, but they were far less confident in streamlining or stopping antibiotic therapy, planning the correct duration of treatment, or using combination antibiotic therapies appropriately. Furthermore, junior doctors felt less confident with the antibiotic dosing, the duration, and making the correct antibiotic choice. Does any of this sound familiar to you, young doctor?
That's it, Prof. That's exactly how I feel. I'm glad to hear I'm not the only one. But I also feel like I don't know where to go when I don't know what to do.
Well, my dear boy, that too appears to be a part of the problem. Incorrect antibiotic prescriptions made by junior doctors often stem from non-compliance with evidence-based clinical guidelines, as well as a lack of support from people who know better, like infectious disease physicians.
Okay, so I understand all the factors why junior doctors, like myself, inappropriately prescribe antibiotics. But what can we do to prevent it?
That's a good question. This is where antimicrobial stewardship comes in. Antimicrobial stewardship is a set of coordinated strategies to improve the use of antimicrobial medications. Now, comprehensive antimicrobial stewardship programs have been demonstrated to reduce unnecessary antimicrobial use by 22 to 26%, with a substantial reduction in pharmacy costs. In addition, antimicrobial stewardship programs have shown to improve appropriate antimicrobial use, reduce institutional microbial resistance rates, reduce patient mortality and morbidity, as well as improve healthcare costs.
Okay, so what do these stewardship programs involve?
Well, antimicrobial stewardship programs generally involve three main recommendations. The first is compliance with the therapeutic guidelines of Australia. The second being involvement in pharmacist-led feedback intervention workshops. And the third involves the creation of a multidisciplinary team, including an infectious disease physician and an infectious disease pharmacist, who can be consulted to optimise the use of antimicrobial agents. The therapeutic guidelines are recognised as the national standard for antimicrobial prescribing in Australia. It reflects best practice on recommending the right agent, right dose, right route, and right duration for antimicrobial treatment. All prescribers should be taught to follow these guidelines and seek expert guidance from infectious disease physicians and pharmacists for situations not covered by the guidelines. The therapeutic guidelines have a simple mnemonic, or the antimicrobial creed, to help you remember some key principles in prescribing antibiotics. Mind me reminds me. The second recommendation includes pharmacist-led feedback intervention workshops. These workshops involve three basic concepts: active education, personalised feedback, and reflection on that feedback. Active education involves clinical pharmacists working with junior doctors to assess their habits and bridge their knowledge gaps. This has been shown to have long-lasting beneficial effects compared to printed material or didactic lectures or group interactions. Also, personalised feedback and reflection on the feedback allows junior doctors to understand the strengths and the weaknesses of antimicrobial prescribing. Literature suggests that reflection on feedback is just as important as receiving feedback in order to improve future prescribing habits. The third recommendation involves access to guidance from infectious disease specialists. Research has shown that intervention from infectious disease specialists has been associated with a significant improvement in appropriate antibiotic prescription, reduced length of stay, decreased mortality, reduction of prevalence of multi-resistant bacteria, and an overall reduction in the overall costs of antibiotics.
That sounds pretty awesome. Are there any disadvantages to these programs?
Well, not all hospitals have the staff and the resources to facilitate antimicrobial stewardship programs. For example, existing programs are usually led by infectious disease physicians or infectious disease pharmacists, and may not always be available in all hospitals. So have you learned something, or have I been wasting my time with the youth of today?
Not at all, sir. Thank you. I understand the importance of appropriate prescribing now, and how to change my irresponsible ways.
Have you? Okay, tell me, what will you do differently?
Well, from now on, I'll be going to the pharmacy workshops and I'll start using those therapeutic guidelines. That should help to identify and fill my knowledge gaps, whilst ensuring my prescribing is in line with evidence-based practice. With better guidance and training, I'll know more and feel more confident in prescribing. I'll also be able to get the ID specialist at speed dial for when I'm unsure about what to do.
Good! Now scram! I have medical students to terrorise.